We're going to start it off. Then there's a question from Dr.
Yes,
Madhu. How do you measure AFI in twins? We do not measure the amniotic fluid index in twins. We normally, in fact, even in singletons, we've started doing the deepest vertical pocket. So that has to be with the transducer. If let's say this is the transducer, you need to be having it perpendicular to the obstetric table, parallel to the midline. Any of the deepest vertical pocket has to be measured, and the normal range is between 2 to 8 centimeters. Less than 2 centimeters is oligohydramnios. More than 8 centimeters is poly. Though I normally follow between 3 and 6, I'm a little more conservative in that. Less than 3, I start feeling that there could be a little trouble, and more than 6, again, I just be a little more careful. But the book says between 2 to 8 centimeters, deepest vertical pocket is normal. Any other questions? Please keep on typing. Ji, are we on YouTube? Do you need to want me to start again?
It started. Now it's coming. Yeah. Sir, now it started on YouTube.
So do you want me to start it from the beginning?
Yes, sir, that will be much more.
I'll do that.
Yeah.
Is the slideshow on?
Yes, sir.
Perfect. This is again a repetition of a few of the slides which the YouTube delegates must have been able to see. So we're going to start off. I'm going to be talking on the multifetal pregnancy, and it's going to be more on twins, and we're going to be talking about basics, the practical aspects on ultrasound, what we need to be aware of, and what we need to be doing. And this is all thanks to Dr. Ritu for providing this platform so we all can interact and chat with each other. Multifetal pregnancies, they account for around 1% of all pregnancies, but nowadays a little more high numbers because of the IVF, or we're looking in for more of IUIs and more of medication going on. There are a few questions coming in the chat box. Now I'll take it towards the end. So if you're looking at this video, you're going to be looking at what is our basic thing, not to jump on what chorionic, what amniotic. No. The first thing is we're looking at gestational sacs, how many gestational sacs, and each gestational sac is giving us what all information. That's most important, and that's what we need to be looking at. The other thing which we need to be careful of, even if you're looking at gestational sacs in the uterus, please do not forget to looking at the adnexa. There are chances there could be a heterotopic pregnancy. That's a zoomed in picture showing this 3 gestational sacs, and each of them showing an embryo and a yolk sac. Cardiac activity seen in all of them. And we know this is going to finally lead to a trichorionic, triamniotic, triplet pregnancy. Pentaplet pregnancy, we're looking at 5 gestational sacs, all of them showing their own embryos, showing their own yolk sacs. We need to sit with the patient depending on what are they planning in for? Are they planning for reduction? What exactly? And similarly nowadays, in terms of the number of embryos being transferred, we're usually doing between 2 to 3. Now we're going to be talking more on twins, and I would request all of you to keep posting the answers, keep asking the questions, and we're going to be looking at that. I do not do invasive procedures, so I'll not be able to tell you about the laser coagulation and all those things. But yes, we'll be able to work out something in terms of on the ultrasound. That's why it is the sonological perspective. The role of ultrasound extremely crucial in the monitoring of the pregnancy, and we need to plan the delivery. The number of fetuses, the chorionicity and the amnionicity has to be determined, because this is what is going to tell us in terms of monitoring for complications and anomalies. Let's have quickly in terms of the short forms, what are the 3 or the 4, whichever you want to type of twin pregnancies. If we can have the answers in the chat box, that would be lovely. Just give a short form. We'll start off with DCDA. What are the other ones?
No one is answering. Why?
No problems, no problems. I think so. There's an answer coming up. MCDA. Hi, Dr. Nupma. I was expecting you're going to be definitely answering. So we have DCDA, MCDA, MCMA. Now the next question comes on. Which one of them is the one which is we're going to be expecting most of the complications out of these 3? We're going to interact. We're going to be learning from each other. Ji. Which is the one which is going to be having the most complications? MCMA, yes. Conjoined twins, we're not going to be looking at straight away, but yes, if we're looking at the in terms of the frequency and in terms of complications where we need to be careful on the monochorionic, monoamniotic, and the least of the complications is going to be in which one? Perfect, in the DCDA. So that is why the chorionicity and amnionicity, I need to be knowing what type of a twin pregnancy. I need to be knowing what I have to counsel the patient, what sort of information the obstetrician is going to be asking. So we need to be aware of. So finding the placental sites of umbilical cord insertion, important again, because you can have marginal or filamentous insertions which can increase the risk of complications. So the twin pregnancies can be broadly categorized into dizygotic twins and monozygotic twins. This is A, this is B. Which one of them is a fraternal twin, A or B? And which one of them is going to be an identical twin? So dizygotic twins are fraternal twins. Monozygotic twins are going to be identical twins. The DCDA is seen in which one? A, B, or A and B? Dichorionic, diamniotic twin pregnancies can be seen in which one? Only A, only B, or AB? I'm going to be explaining all step by step, so don't worry about that. It can be seen, this dizygotic twins is always a dichorionic diamniotic. Monozygotic can be dichorionic diamniotic. I hope everybody is getting, yeah, perfect. So if the twins are arising from the fertilization of 2 sperms and 2 ova, it's a dizygotic twin. And monozygotic, when there's a fertilization of 1 sperm and 1 ova, the zygote is formed, and depending on when the cleavage or when the division occurs, you're going to be having different type of twin pregnancies. Dizygotic, known as fraternal twins, independent fertilization of the 2 ova. They result in dichorionic diamniotic twin pregnancies. This feature alone cannot be used to distinguish dizygotic from monozygotic, because approximately 20% will also be dichorionic diamniotic in terms of the mono ones. Monozygotic twins are known as identical twins, and they're because of a fertilization of a single ovum that separates into 2. Monozygotic do not have maternal age, family history, or ethnic predisposition. The time at which this separation occurs determines the chorionicity and the amnionicity of the pregnancy. So that's how you're looking at dizygotic twins, monozygotic twins. Dizygotic, you can see separate sperm, separate ova. So we know it's a dichorionic, diamniotic. Monozygotic, a zygote is formed. And the moment we're looking at, in terms of the morula dividing, we're going to be looking at dichorionic, diamniotic. The morula gets formed. At the hatching level, there's going to be a splitting. It's going to be single placenta and two amniotic sacs. If we're looking at not the hatching, but at the blastocyst level, there is a division. It's going to be momo twins or monochorionic, monoamniotic. So let's have from the time of cleavage after fertilization. If the cleavage after fertilization from 0 to 3 days happens, what type of monotwins are you going to be expecting? DCDA, MCDA, or MCMA? 0 to 3 days is going to be a DCDA happening over there. Dichorionic, diamniotic. We're looking at 4 to 8 days. We're going to be now looking at the moment the cleavage takes place. The next is going to be monochorionic, diamniotic. 9 to 12 days is going to be a monochorionic, monoamniotic. And if the cleavage takes place after 13 days, we're looking at conjoint twins. You can just go through this because this is extremely important to tell us what are we looking at. Now, what is the sequence of events that we need to be looking at? We need to be dating the pregnancy. We need to be determining the gestational age. We need to be looking at chorionicity and amnionicity. We need to label the twins. The timing, the frequency, and what all has to be seen in the ultrasound assessment is most important. In terms of dating, it should ideally be dated when the crown rump length. Yes, it's okay if you're doing it between 8 to 9 weeks, that's also fine. If you have done an IVF procedure, you're sure of when the embryo transfer was done, at what level have you done that? So you can automatically add whether you need to add plus 14 or plus 18. But if you're looking at somebody who's conceived naturally, has a twin pregnancy, you're seeing it, it is always ideal to do it between 11 to 14 weeks or 45 to 84 millimeters. Everywhere we can't be doing plenty of ultrasound, so we need to be aware. Now, in terms of the pregnancies which have conceived spontaneously, if you've done an embryo transfer, you're sure of. The larger of the two crown rump lengths should be used to estimate the gestational age. Why do we need to do that? Because if you're looking at, let's say, there is some sort of, for some reason, for a very, very early FGR, and you take that as a dating, that as the true one, we're going to be bound in trouble. Always better to be conservative, so that let's take the larger of the two CRLs so that we don't make a mistake. Now, question for you all. How many gestational sacs are we looking at over here? We're looking at 2 gestational sacs. In each gestational sac, again I repeat, in each gestational sac, how many yolk sacs? In each gestational sac, we're looking at 1, or yes, that's also correct. We're looking at 2 yolk sacs and we're looking at 2 embryos. So finally, what sort of a twin is this going to be? What sort of a twin pregnancy is it going to be? It's going to be a dichorionic, diamniotic. Perfect. So that's how even in the first trimester, very, very early, you can look in for what type of a pregnancy. Now let's see another one. How many gestational sacs? How many gestational sacs are we looking at? And how many yolk sacs are we looking at in the gestational sac? We're looking at two yolk sacs. That's one yolk sac. That's another yolk sac. Again, see that we're looking at a nice thick decidual reaction. We're looking at a single gestational sac and we're looking at two yolk sacs within. Right. How many gestational sacs? We're looking at a single gestational sac. How many yolk sacs in the gestational sac? We're looking at two yolk sacs in the gestational sac. How many embryos in that single gestational sac? So what type of a twin pregnancy this would finally land up to be? DCDA, MCDA, MCMA, A, B, C. So this is going to finally land up into a monochorionic diamniotic because they're two yolk sacs. Two embryos seen over there. We're looking at nice cardiac activities. We're looking at their individual amnions and we're looking at a yolk sac. Two yolk sacs. We're looking at a dichorionic diamniotic. This is going to finally land up, but again, we are going to be labeling two gestational sacs and each gestational sac shows us a yolk sac and an embryo. We're looking at a thin interamniotic membrane. What sign is this? What sign is this which is absolutely perpendicular? What sign is this? This is a thin interamniotic membrane. This is perpendicular to the gestational sac wall. I repeat the whole thing. What sign is this? This is very, very thin. That's a T sign. Perfect. Yes. Because the thickness of the membrane, how it is going there is going to decide. We're looking at two yolk sacs. We're looking at two embryos within one gestational sac, MCDA. This is also MCDA. So that's how you're looking at the placentation, the gestational sac, looking at yolk sacs and the embryos. But again, a word of caution. In biology, nothing can ever be 100%. This was a patient who would come at around 10 weeks and I could clearly see two yolk sacs, but there was a single amnion. Both the fetuses were in one amnion. So two yolk sacs normally means diamniotic, but there was no way I could see another membrane in between them. It was finally a monochorionic, monoamniotic, though I was looking at yolk sac. So exceptions can always be there. So never go that it has to be and it will always be this. We need to be using our brains judiciously to figure out so that whenever these changes happen, we are aware of them. Looking at yolk sacs, all twin pregnancies, they have a higher fetal and neonatal mortality, with overall rates being 3 to 6 times that of a singleton pregnancy. Neonatal mortality is 7 times that of a single pregnancy. It's because of a prematurity. The moment it's a twin pregnancy, the patient is also aware, we are also aware, and we need to be telling them that there could be a premature delivery. So we need to be careful. And plenty of sequelae after a premature delivery follow. That is why we have such a high incidence of neonatal mortality. The risk of complications depend on the chorionicity. Prognosis worse for mono and best for dichorionic diamniotic. 10%, 20%, more than 50%. So we need to be very watchful. These are the various complications: IUFD, structural anomalies, growth restriction, discordant growth, premature delivery, cervical incompetence, placental abnormalities, marginal and filamentous insertion. Risk of infant mortality, 5 times. Major malformation, 2 times. Minor malformation, 1.5 times. So twins means you need to be cautious. You need to be more aggressive. You need to be calling them quite often so that you don't miss out on that. Chorionicity should be determined before 13 weeks and 6 days using the membrane thickness at the site of insertion. You can identify the T sign or the lambda sign and the number of placental masses. If one placenta is anterior, one is posterior, you're comfortable about it, there's no hassle. But if both of them are fusing, then you need to be watchful. At the time at which chorionicity is determined, looking for the amnionicity, looking for the amniotic membrane, and document it as well. So to figure out, you need the membrane thickness, the number of placentas, you need to be looking for any umbilical cord entanglement. The lambda sign. It's basically placental tissue going inside, which makes this appearance of a lambda sign. T sign is there is no placental tissue going inside. That's why it's perpendicular. This is placental tissue. Let's say this is placenta, this is placenta, placental tissue going inside the membrane. In this case, it's a single placenta with 2 membranes. So 2 separate placentas, we're clear about it. Lambda, we're clear about. T sign, we're looking at monochorionic diamniotic. 1 yolk sac, 2 embryos, monoamniotic. Entangled cords or cord of one fetus around the other fetus. Obviously, we know they can roam around and they can be doing this. So this is monoamniotic. You're looking at 2 gestational sacs. Each embryo is surrounded by their own amnion. In terms of dichorionic, the chorion extending between, we're not able to. We're looking at separate gestational sacs with chorion extending between the membrane over there. Less than 10 weeks. We're looking at a twin peak sign or a lambda sign that starts off after 10 weeks. And you're looking at a thick inter-twin membrane, more than 2 layers, because we're looking at amnion amnion, and placenta in between. Separate placental masses. Most dichorionic pregnancies have placental masses that could be close to each other. They could be abutting each other. Thickness, subjective and becomes progressively more difficult to assess. So in first trimester, we always a little more smarter in terms of looking at that. A dichorionic diamniotic is a type of twin pregnancy. Each twin has its own chorion and amnion. Most commonly with dizygotic, but with monozygotic as well. And we're looking at two gestational sac with a thick echogenic chorion surrounding each embryo. More than 2 millimeters is the thick intertwin membrane. You could be looking at a twin peak or a lambda sign. You could be seeing two yolk sacs. This does not differentiate a DCTA because you can have two yolk sacs even in an MCTA, but we are aware of all the other findings. I'm just trying to tell you what all can overlap, so don't get confused about it. When there's no placental fusion, we are looking at two separate placental sites. Life becomes much more comfortable and easier. They carry the lowest rate of complications. But what all are the complications that could be? Is an increased risk of FGR, velamentous cord, marginal cord, or placenta previa spectrum. We have the placenta related problems. What sign are we looking at over here? We're looking at two placentas close to each other. What sign is this? We're looking at the lambda sign, and you can see for the membrane as well. But the moment you can see the placenta going inside, we know that's the lambda sign, and it has to be a dichorionic diamniotic twin pregnancy. In which condition can you see a dichorionic monoamniotic twin pregnancy? In which condition can you see a dichorionic monoamniotic twin pregnancy? You can never and never see that because that never happens. It cannot be a dichorionic monoamniotic twin pregnancy. Never happens. So we're not looking at that scenario. That's the only combination that's not possible. There you're looking at the lambda sign. Looking at the lambda sign, you can see the difference in terms of the thickness of the membranes. Now coming on to monochorionic diamniotic. One gestational sac, two yolk sacs. You can see a thin intertwin membrane. You can see a single placental mass. Most dichorionic pregnancies can have placental masses close, so you could make that mistake, but we need to be smarter. In that case, we're not looking at a T sign. What sign is this that we're looking at? What sign is this that we're looking at? It's running perpendicular. That's the T sign. Monochorionic diamniotic subtype of monozygotic. They share a single chorionic. Then we're looking at a twin pregnancy with a single gestational sac, but separate yolk sacs, as I cleared it earlier. 14 to 18 weeks, you can see a single placenta, and that's what differentiates it. You can look in at a thin intertwin membrane because the amnions are abutting the placenta. This differentiates it from a monochorionic monoamniotic. It's very thin, less than 2 millimeters. That's how it differentiates. And we're looking at a T sign of the inter-twin membrane. Number of placental masses, thickness of the membrane, presence or absence of twin peak sign tell us about what type. The problems are related to abnormal placental vascular anastomosis, twin-twin transfusion, twin embolization, trap sequence, twin reversed arterial perfusion. You could be looking at the demise of one twin. That's often associated with an adverse outcome for the other one as well. And because of placental insertions, the umbilical cord inserting, you could be looking in for other troubles as well. Monochorionic amounting to 20%, they account for 30% of pregnancy-related complications. You need to be careful because of the hemodynamic complications. Like twin-twin transfusion syndrome, you can have a twin anemia polycythemia sequence. We're not going into too much of details because I wanted to keep it basic. And I wanted all the stuff so that we are much aware of it. We can look in for the acardiac twin when we're looking at a trap sequence. We can have a demise of a co-twin, a twin embolization syndrome. There can be discordancy of the amniotic fluid, which is the most reliable predictor that problem is starting. Complications, these are unique to monochorionic twins. What type of a pregnancy is this? How many gestational sacs? We're looking at 2 gestational sacs. How many embryos or fetuses? So we're going to be looking at a triplet pregnancy. We're looking at 2 placentas, but we're going to be looking at these. This one, the so-called twin, is going to be more of a monochorionic diamniotic, and that's going to be the other one, which is going to be comfortable. The Momo twins, no intertwin membrane, 1 yolk sac, and entangled cords are quite common. Again, a subtype of monozygotic, they share a single chorionic sac, a single amniotic sac, and a single yolk sac. So when we're looking at a single gestational sac with a single yolk sac, this differentiates. That's how the first trimester or the initial 7 to 8 week scan is so important. No intertwin membrane. But we need to be careful, even in monochorionic diamniotic, sometimes looking at an inter-twin membrane can be difficult. There can be presence of cord entanglement, cord fusion. We can have an absent intertwin membrane. This are common to monochorionic, mono and di, a single placenta seen, and an absent twin peak or a lambda sign. Highest level of potential complications. They share 1 amniotic sac, so there's plenty of cord accidents happening. Conjoined twins can occur in only monoamniotic pregnancies. Cord entanglement, conjoined twin. You can still have placental vascular anastomosis still, even in a momo twin as well, though it's more common in monochorionic diamniotic. So now we're going to be dealing with how often and what all has to be seen in for. The labeling is extremely important. So either you can label them as a gestational sac, which is on the right or the left side, superior or inferior, or you can have your own way of labeling, put it in the report so that next time anyone else does it or you do it, you're sure of that you're looking at the same fetus, not the other one, so that the biometry doesn't change. Initially in the first trimester, it would not make that much of a difference, but second trimester onwards, it will make a huge difference. So the strategy every time with that particular pregnancy has to be consistent. How often are you going to be monitoring uncomplicated dichorionic twin pregnancy? You need to be looking in for the first trimester scan, a detailed second trimester scan, and then you need to be scanning them every 4 weeks. If there's a complication, as frequent as you need to be. So that's how you're looking at 11 to 14, dating, labeling, chorionicity, screening. Anomaly scan, and then every 4 weeks. How often? Monochorionic. Uncomplicated, you're doing a first trimester scan every 2 weeks. After 16 weeks, and there's a complication quite often. So you're doing your 11 to 14, and then from 16, 18 weeks onwards, you're looking at deepest vertical pocket. Why do we need to be looking at deepest vertical pocket in monochorionic diamniotic? To rule out which complication are we going to be ruling out the moment we start assessing the Likert in both of them? Because the first thing to go up and down is going to be oligo in one and poly in the other. Then we're doing our anomaly scans. We're doing a detailed anatomy, biometry, DVP, this, cervical length. Why are we looking at middle cerebral artery peak systolic velocity? Why are we looking in for what sort of a complication? We're trying to look in for the anemia polycythemia sequence. Absolutely, the TAP. So that's how we need to be careful, and we need to be doing this every 2 weeks so that we do not miss out on it. Now, in terms of screening for chromosomal abnormalities, you can do it in your 11 to 14 week scan. You can have your beta HCG, the dual markers as well, and you can do a combined, but you need to be watchful in terms of looking in for these things can sometimes be troublesome. Because the lab has to have those normal values, those control values. So you need to be very, very careful, and even more careful to look in for with just maternal age and NT to screen for chromosomal anomalies. If you're looking at dichorionic twins, each and every gestation, the twin is going to be labeled separately, and you're going to be giving them a risk factor. The one on the right, the one on the left. But if you're looking at a monochorionic twin, we know the chromosomal substance for both of them is going to be the same. So you're going to be averaging it. Let's say one side was 1.4, the other twin is 1.8. You're going to make it 1.6 and calculate the risk factor, the a priori risk and the risk after you've done your NT. In case of a vanished twin, there is still a measurable fetal pole. NT alone in combination with maternal age should be used for risk. There are various things where they say if it's more than 8 weeks or you're not able to see it, you could still use that. I wouldn't be the right person to be really letting you know about that. The detection rate of non-invasive, the NIPT for trisomy 21 may be lower in twins than in singletons. Now we're looking at a discordance in the NT or the CRL in the first trimester. What does that imply? You're looking at a CRL discordance of more than 10%, or you're looking at an NT discordance of more than 20%. You need a detailed ultrasound assessment and a testing. The risk of fetal abnormalities is 25% if the discordancy is more than 10%. And it's 4% if the discordancy is less than 10%. So it jumps up almost 6 times. If the NT discordance is more than 20%, sensitivity and specificity for the development of twin-twin transfusion. This is for 11 to 14 weeks. But at 7 to 10 weeks, if you're looking at discordancy, it's a predictor that there's a risk of single fetal demise. In terms of ultrasound screening for structural abnormalities, you need to be carefully seeing from the head till the toes for any major anomaly. In the first trimester as well, not that we're going to be doing it in the second trimester, so I don't need to see it in the first trimester. Please be careful. And the second trimester, 18 to 22. Now we have the MTP going up to 24, so we can do our anomaly scans nicely between 20 and 22. Monochorionic twins is a definite indication for a fetal echocardiography. No doubts on that. The risk of fetal anomaly greater in twins, 2 to 3 times higher in monozygotic. In dizygotic, it's the same as in singletons. In monozygotic, 1 in 25 for dichorionic, 1 in 15 for MCDA, and 1 in 6, you can see it's so high for momo twins. Now comes on to the risk of preterm birth. Cervical length measurement. We have 25 millimeters as the cutoff. Spontaneous and iatrogenic preterm births more common in twins than in singleton. There's lots of debate on the moment it's a twin, the moment it's so-called precious pregnancy, should we put in a cerclage? That's not for me, but for obstetricians and you all to be debating whether that's required or not. More than half of twins are born before 37. So it's the 60% and 12% for at 37 or 32 weeks of gestation. As the higher order comes in, you can see the risk of premature deliveries 5 times in twins and 9 times in triplets. The other complication we need to be watchful for is FGR. Selective FGR is defined as a condition in which one fetus has a weight below the 10th percentile, or the inter-twin discordance is more than 25%. At the discordance, we normally have a cutoff at 20%, and I'll tell you how are we going to be doing that. This distinguishes pregnancies which are at an increased risk of adverse outcome. In fact, today only we were discussing in our Sono School 2022 group that there was a patient, dichorionic, diamniotic, there was a discordance, and one of the fetuses was showing a middle cerebral artery. The PI was less than 1 and the CPR was also less than 1. So it was advised amongst the group that yes, the termination needs to be done. How do we calculate the discordance? The larger twin minus the smaller twin weight divided by the larger twin weight into 100. That's how the discordancy is calculated. And you all have to make a habit of the moment you cross your second trimester or you've done your anomaly scan, try and mention the discordancy. In terms of monochorionic twin pregnancies, which are complicated by selective FGR, we have a specific one on Doppler. How are we going to be using that? And in this, umbilical artery is extremely helpful. We have type 1, where we are looking at positive end diastolic flow, but reduced. Survival is greater than 90%. We need to be looking at how's the brain sparing, how's the ductus venosus, what week of gestation are we looking at. So we're looking at positive flow, meaning there is flow in diastole, it's still not reached absent end diastolic flow. Absent or reversed is seen in type 2, which is again associated with a high risk of IUD, associated risk of neurodevelopmental delay. We're not interested in just giving them a baby. The baby has to be fit and fine with a good APGAR score. After 2 years, after 10 years, there should be no neurodevelopmental delay. We need to be watchful. We know if there's going to be a neurodevelopmental delay if the other twin survives. So if you're looking at an IUD of either twin in up to 29%, risk of neurological sequelae in up to 15% of the cases born prior to 30 weeks. Absent end diastolic flow. If you're looking at a cyclical or an intermittent pattern of absent or reversal, 10 to 20% chances of a sudden death of a growth restricted fetuses. It can be quite unpredictable. And then that's when you have to think of, should we be delivering? Should we be having a premature? Should we be causing the other baby problem? So a constant monitoring needs to be done. There's a high up to 20% associated neurological morbidity rate in the surviving larger twin. Now, in terms of follow-up of twin pregnancies, how are you doing it? In dichorionic, if you're looking at a selective FGR, the fetal Doppler has to be assessed almost every 2 weeks, but again, depending on the severity. In monochorionic, Doppler has to be done at least weekly. But the moment we're looking at that there's other problem coming up as well, this is when we're looking at positive flow in diastole in the umbilical artery. So to summarize, the ultrasound assessment of fetal biometry, anatomy, Doppler velocimetry, and amniotic fluid volume. All this is important, but the amniotic fluid volume, the moment you're putting in your probe, that eyeballing has to tell you, should I be worried about something or not, is used to identify and monitor twin pregnancies at risk of adverse outcomes. As in singletons, impaired fetal growth can be assessed in twins by comparing biometry and Doppler velocimetry against the standards for uncomplicated pregnancy. So be very careful. Each and every scan that you're going to do is going to give you loads of information. Be very careful in seeing those findings. Somebody else has done it. Please go through the pictures. Might be they're not mentioning something which you could be catching in for. And if you're doing on your own, you've seen what all are the things you need to be doing in for. So do that so that we can stretch the pregnancy as far as possible and try and make sure that both the babies, in if it's a twin pregnancy, are given to the parents and both of them are hale and hearty. Thank you. Thank you so much.
Thank you, sir. Thank you. Thank you so much for such a nice presentation. Sorry, there is some problem in the internet connection. Actually, it's very windy and raining here. I don't know. I'm not able to connect from my laptop.
Okay, so, no problems. No problems.
Sir, thank you so much. Thank you so much for such a nice presentation. Let me just go through the chat box if any questions are there.
Sorry, there were plenty of these chats, so the questions must have gone up. So if there's any question, you can please type it again. I'm sorry, because I always like to interact, so this happens. Yes. So if there's any question, you can just type it again.
Meanwhile, I'm checking on the YouTube also for the questions. Yeah. Nishant, are you able to see some questions? Because I've just logged in from this device now, so I am able to see.
Yes, ma'am. Let me check.
I'm just going through the chat box. I'm going absolutely high up. There were 2-3 questions.
Yes,
Let me just check that. Once the answers are through, yeah.
There was one question from Dr. Dinesh Agrawal. Can we see FHR by Doppler waveform in first trimester?
No, we don't need to. Why should we be doing it when we can eyeball the heartbeat and see it, and we can calculate the heart rate by M mode? It should always and always be avoided, because we are not sure of the 2 bioeffects that ultrasound can give. One is thermal, the other is mechanical. So we shouldn't be taking any chances. Do not we tend to overdo in terms of making sure, okay, let's make them listen to the heartbeat, they'll feel happy. But that should always be done from your NT scan when you're looking for tricuspid regurgitation. If we're talking about 7 to 8 weeks, if we're talking about 11 to 14 weeks, yes. But again, the principle of ALARA has to be followed. That is as low as reasonably achievable. So whatever is required, just do that. Don't unnecessarily put on Doppler on the baby. So in terms of looking at Doppler in your 11 to 14, You're just supposed to be looking at the ductus venosus and the tricuspid regurgitation. That's all that's required.
Okay, sir. And the second question from Dr. Dinesh Agrawal is, so in first trimester, can we see by Doppler
That's
wave?
exactly
The
the same
same
thing.
question,
The
yeah.
same question, you need to be doing the M mode. Again,
Yeah.
if one twin dies at 28 weeks, then you need to be watchful. What type of a twin? How is it going to be affecting? Because if it's a monochorionic, the other is going to be going to get affected quite soon. So you need to be very, very, very watchful.
So, doctor,
And
In a
Dr.
dichorionic diamniotic, there's nothing to worry. You might be just needing to see them every week. You need to
Yeah.
tell the patient to make sure that they're feeling the movements, because if it's a dichorionic diamniotic, you can take them till the end. Again, depends on if we're not looking at any other problems.
yeah. Here I want
All
to,
the, sorry, I'm just, you need to be doing your blood profile, the patient's blood profile, all that has to be carefully done so that we don't get into any surprises. Yes, Dr. Ritu, you're saying something.
exactly, sir, the blood coagulation profile only I am going to say. And Dr. Chinmay, here I want to add, because there is not such any tailor-made protocol. Every time we have to decide based on the clinical conditions that how the patient is progressing at the time of the death of the one fetus. So there are a lot of parameters. Soon I am planning to have another lecture. Today we have covered the sonological, and next time we cover the clinical perspective. Yes, sir. Nishan, you can take other question.
So that was the one question from Dr. Chinwe. If one twin dies at
Okay.
28 weeks,
Okay.
what to
Okay.
do? Yeah.
Chinmay is a dear from Nigeria. Yeah, thank you for joining.
Thank you, Dr. Chinwe. Thank you.
So I cannot see any more question, ma'am.
Okay.
Yeah.
I normally tend to confuse so much that nobody is asking a question.
No, sir. Such a
Okay, we got one
Dr.
feedback.
Yeah, please take that question. Dr. Nishan, Kariman has
Yeah.
asked.
Yes, Dr. Kariman Ghazal is asking, do you advise for every multiple pregnancy to take a progesterone from 6 weeks since 36?
That Dr. Ritu is going to be answering because I am nowhere in that picture.
Yes, Dr. Kariman, usually we are doing this ART procedures. Yes, of course we are giving, but not up to 36 weeks. In some patients, I'm giving up to maximum of 18 weeks or 20 weeks. Yeah. Dr. Kariman,
Dr. Kariman, please unmute. Ma'am, please unmute yourself.
Dr. Kariman, we can't
Dr.
hear you,
Kariman?
Ji.
she's dropped
Okay,
the
ma'am.
Yes,
file.
you
Yeah,
advise.
Yes,
now we
ma'am.
can
Now
hear
we can
you.
hear you.
Yes, you advise for every multiple pregnancy to take progesterone, eh?
See, Dr. Kariman, I am
Yes.
a RT specialist, so mostly my patient by IUI or IVF are conceiving this. If the twin pregnancy, yes, of course we are giving. I don't want to hide anything, but yes, of course we are giving. Here, we are giving lot of progesterone. We are giving macronized progesterone. We are giving progesterone injection also. Some patients now we are giving the dydrogesterone also. Yes, we are giving. We are giving.
Okay.
And there is one feedback from Dr. Dinesh that please make one session on anomaly scan.
Yes, sure. We will do, Dr. Dinesh. I will request again Kuldeep Singh sir to take that session.
No problem, Ji. We'll definitely make a program.
Yeah. If the questions
Yes.
are finished,
Yes,
Nishant,
yes,
so
yes, ma'am.
my round.
Yes, ma'am. Sure.
Sir, as this is the show's name is the Icon in Conversation with Dr. Ritu. So there are now academic questions and non-academic questions also. So now we are coming to a non-academic part. Sir, that you have to answer in one word without taking much time.
Okay.
Uh,
I'm getting scared.
No, sir, my first question to you. Sir, you are role model for many of us. Who is your role model?
Dr. Shokrana.
Okay. Sir, can you share any of your one childhood memory with us?
I'm from Lucknow, so it's not going to be one word. and there used to be a tube well in front. So we used to, all our friends go there and have a bath, and the tube well wala used to just switch it on. So it used to be good fun.
Okay, okay, great, great. Sir, any message you want to give to the upcoming doctors?
There are two things that I always say in every Sono School session that we have. The eyes are going to see what the mind knows. So keep that absolutely open. And the other thing which I tell everyone is that if anyone can do it, you definitely can do it. Never feel, no, this is not my field, why should I be doing it? Either don't do it. If you're doing it, do it completely wholeheartedly, and you'll definitely be able to do it. We all, the gray cells everywhere are the same. And if anyone can do it, we are definitely going to be doing it. Never hesitate in taking all these steps, and you're going to be doing wonders, all of you.
Yes, very true, sir. Thank you so much. Because impossible is not the word. I have to make it possible.
Absolutely.
Yes. Yeah. Sir, my other question. Sir, you are a tea lover or coffee lover?
Tea lover.
Tea. And sir, what about your favorite color?
Red.
And favorite fruit?
Favorite fruit, I like a pear.
Which fruit, sorry?
Pear.
Pear. Okay. Sir, any place where you love to visit in future?
I have to go to Tanzania, ji. There's a patient of mine who's been telling me to come over there. And they say that the resorts are so beautiful that you step out of your room and you're going to be seeing giraffes. So I have to go there, ji.
Okay. Sir, we all know that you are a very good and great accommodation. Sir, please share us with your other hobbies with us.
I love listening to music. I love playing video games.
Okay, great. So many things I came to know today only about you. So thank you once again, sir, for sharing your immense knowledge with all of us.
Thank you so much.
With this, we will wind up the session for the today. So friends, please stay tuned with us on next Thursday, same time, 8:30 p.m. Standard Time, Indian Standard Time, 5 p.m. Kerio time. And next week, we are having Dr. Ayman Saheta with us from all the way from the Tanta University, Kerio. He is going to speak on the ovarian torsion. And thank you once again, my dear friend Nishant from the Shield and Chitra for providing us the platform and always being so supportive. Thank you once again.
Ma'am. Thank you, sir.
Thank you, Nishant. Thank you, Dr. Ritu. Thank you so much.
Yeah.
It's always a pleasure to be with you. Thank you.
So much, sir. Bye-bye.
Thank you, Dr. Madhu. Thank you so much.
Thank you, doctor.
Thank you, Dr. Kariman. Thank you so much.
Thank you so much.
Thank you, everyone.